All right, if you're a PA student getting ready for your boards, you know there are some topics you just have to know cold. And today, we're diving deep into one of them, acute pericarditis. This is your high-yield review, designed to make sure you absolutely nail these questions every single time. Let's jump right in.
You're staring at your screen on exam day, and this case pops up. Sharp chest pain, worse lying down, better leaning forward. Instantly, one diagnosis should be screaming at you from the top of your differential. Yep, this is the classic textbook setup for pericarditis, and we're going to break down exactly why. So what are the absolute must-knows, the essentials of diagnosis? We're talking about that specific pleuritic chest pain, the one-of-a-kind pericardial friction rub, a possible fever, and of course, those super high-yield ECG changes, diffuse ST elevation, and PR depression. We're going to hit every single one of these so they're locked in your brain.
Okay, first things first. Let's paint the picture. What does this patient actually look like, feel like, and sound like when they walk through the door? It all starts with the history and the physical exam. Now, this isn't just any chest pain. It's sharp, it's right under the breastbone, and it's pleuritic, meaning taking a deep breath just makes it so much worse. But here's the money shot, the huge clue. It's positional. The pain is awful when they're lying flat, but gets way better when they sit up and lean forward. That right there is a massive clue pointing you away from a heart attack and straight towards pericarditis.
And here it is, the absolute, can't miss it, pathognomonic physical exam buzzword, the pericardial friction rub. It's this high-pitched, scratchy, almost leathery sound. You know, if you hear that described in a question, honestly, you're already halfway to the right answer. It's that specific.
Okay, so we've got the presentation down. We know what to look for, but why is this happening? What's actually causing all this inflammation? Getting a handle on the etiology is super important because, as we're about to see, the cause can totally change how we manage it. By far, the #1 cause is viral. Coxsackie virus is the classic bug they love to test. In fact, a ton of cases just get labeled idiopathic, which really just means we're pretty sure it's viral, but we haven't proven it. Now, you also got to keep a few other high-yield causes on your radar. Uremic pericarditis in your chronic kidney disease patients, and of course, Dressler syndrome, which can pop up weeks after a heart attack. All right, now we're getting to the stuff that's going to earn you points on the PANCE. How do we lock this in? How do we confirm the diagnosis? It's really all about putting the puzzle pieces together from the history, the physical exam, and a couple of key tests.
Here is a beautiful, simple rule to carry with you into the exam. The 2 of 4 rule. To officially diagnose acute pericarditis, you just need 2 of these 4 things. It's the perfect mental checklist to run through when you're faced with one of these clinical vignettes. Super easy to remember.
Okay, hey, if you're multitasking, come back to me for this one. For real.
The ECG is without a doubt the most tested part of this whole condition. You absolutely positively have to be able to spot these findings.
The key word here is diffuse. We're talking widespread ST segment elevation. You'll see it in pretty much all the leads. That's totally different from an MI, right? An MI has localized ST elevation and those reciprocal changes. With pericarditis, you don't see those reciprocal changes. And hey, don't forget to hunt for that PR depression. It's another huge giveaway. And for all you fans of classic buzzwords, here's another one for your collection, the water bottle sign. If you get a chest x-ray and the heart shadow looks like a big globular water bottle or a flask, that's a telltale sign of a large pericardial effusion, just a whole bunch of fluid building up around the heart. Now for labs, you're expecting to see inflammation, so it makes sense that your ESR and CRP will be up. But here's a tricky part that can trip people up. Don't be surprised if you see a slight bump in the cardiac troponins. It happens in about a third of cases, means there's a little bit of heart muscle inflammation too, but it doesn't automatically mean the prognosis is worse. So we've nailed the diagnosis. Now what? What are we going to do about it? Well, let's walk through the treatment plan. It's actually pretty straightforward. First-line therapy is basically a 3-part cocktail. Step 1, hit them with a strong anti-inflammatory, like a high-dose NSAID or aspirin. Step 2, and this is crucial, you add colchicine for 3 months. Why? Because it dramatically reduces the risk of this thing coming back. And step 3, since you're using high doses of NSAIDs, you gotta protect that stomach, so add a PPI. Now pay attention, this right here is a huge distinction, a classic PANCE trap. If the pericarditis is post-MI, that's Dressler syndrome, you have to use aspirin. Not ibuprofen, not naproxen, just aspirin. That's because other NSAIDs can actually mess with how the heart muscle heals after a heart attack. So just burn this into your memory. Post-MI pericarditis equals aspirin. Period. So the good news is most cases of simple viral pericarditis get better no problem. But you always have to be on the lookout for red flags. So let's talk about the scary stuff, complications, and what makes a patient's high risk. The big, scary complication we all worry about is cardiac tamponade. That's where so much fluid builds up that it starts squeezing the heart so it can't fill with blood properly. It's a true medical emergency. Thankfully, it is pretty rare, happening in less than 5% of cases. So, what should make your spidey senses tingle? Here is your high-risk checklist. Watch out for a high fever, a really large effusion on an echo, any signs of tamponade, or a patient who just isn't getting better after a week of treatment. Any of these are a sign that this case is more serious and points to a poor prognosis. So there you have it. You're now totally ready to diagnose and manage a straightforward case of acute pericarditis. But here's where the real thinking begins. What do you do when that first-line therapy doesn't work? What happens when it keeps coming back? And what are the absolute must-refer indications to send your patient to cardiology? Answering those questions, well, that's what makes you a great clinician. Thanks for tuning in.